Okay, what I wanted to go over you guys with you was your score from today on the ATI mastery test. So you can see when you go and look at your scores, you're going to have a percentage score when you look at your mastery exam, and you're also going to have a level next to that score. So based on the percentage, that's what tells you what level you're on. Every mastery exam is a little bit different. So the mastery exam for pharmacology or foundations might have a little bit different percentages that will put you on different levels, but they're pretty similar. So what I want you guys to know about the different levels, like what they mean. Level 1 means they essentially, if you were going to be tested with the NCLEX today, just on the MedSurg content, right? They wouldn't be looking at maternal peds or anything like that, just on MedSurg. Level 1 means they don't think you would pass the NCLEX. Or pardon me, below level 1. Level 1 means you need minimum competency, but it's not likely, like it's a 50-50. Who knows if you would actually pass it. Level 2 means you probably will pass the NCLEX on this material. And level 3 means they're pretty much sure you're going to exceed level that you need to pass the NCLEX. So what we're shooting for everybody is to be, by the end of the program, when you're taking these mastery tests, to be at level 2 or hopefully level 3. Right now, you guys haven't even had MedSurg 3 yet. You know, we haven't covered diabetes. We're still partway through the program. So not getting to level 2 or level 3 is not that big of a deal right now, but I want you to keep in mind as you progress through the program, we want to keep leveling higher and higher, because these scores that ATI gives you are pretty consistent. I'm going to be teaching your guys' transition to professional practice class that you'll take in the summer. And part of that class is your capstone, which essentially every week you'll be taking an ATI mastery test on different topics. So one week it might be mental health, and then you do remediation. And the next week it might be pharmacology, and then you do remediation. It's going to give you levels and scores like that whole term. And so I want you just kind of to think about where you land on these levels. It will tell you, basically, if you think they can predict whether you're going to pass or not. The students that I've seen who reach level 2 and level 3 almost always pass the NCLEX. The students who really struggle and stay back here in level 1, or maybe reach level 2, not very well into the percentages, they are ones who don't always pass the NCLEX. Okay, so it really does give you a good feedback of if you're prepared to take the NCLEX. So just an idea, if you already reached level 2, I would feel pretty proud of yourself right now, because you've done pretty well without having learned all the MedSurg content. If you're level 1, that's okay. I would start looking at how do I move to level 2. If you score below level 1, even though we haven't had all the content, that kind of speaks a little bit to test taking skills as well. And so if you're below level 1, I want you to make sure you go back and look at how you're taking the test. You might need to work on some of your test taking strategies. Doesn't mean you're not going to pass. It means it gives you a good indicator of what you need to do to be successful. Any questions? Not so much? Okay. So the first thing I want to do with you guys is actually watch a little video. I really like the osmosis videos, and in your okay, this is your week 9. I kind of put like week 9 and 10, the resources pages together. Osmosis videos were just really long, and a lot of the ones that were free to everybody to watch were more targeted at medical students, so like a doctor. But I felt that this video with the Khan Academy was pretty good at looking at diabetes from a nursing perspective. So we're going to watch this video. It's about 8 minutes, I believe, and then jump into our lecture.
So diabetes is a very common disease. It affects nearly 10% of the population, and more than 25% or 1 in 4 people over the age of 65 have diabetes. But what exactly is diabetes nowadays? Let me start by going through a couple of scenarios. Now, the first scenario I want to talk about is that of Joe here. So let me bring in Joe. Now, Joe is a 15-year-old boy. Over the past few months, Joe just really hasn't been feeling well. He says, it's hard to kind of put a finger on it, but he's in general been a little bit more tired and fatigued than usual. In fact, it's caused him to lose a little bit of weight, and he's already kind of a skinny guy to begin with, so that's definitely something that's abnormal for him. And, his mother's with him. His mother says, it's kind of been odd. Joe's been carrying around this water bottle with him everywhere for the past few months. He seems to just be drinking liters upon liters of water a day. And when asked about it, Joe acknowledges this. He says, yeah, I have been a little bit more thirsty than usual. And because of this, I've been going to the bathroom and continuing to urinate all the time. Now, let's contrast Joe to Bruce here. Now, Bruce is very different than Joe. Bruce is a 45-year-old gentleman, and he's coming to the doctor for his annual physical. And when he goes to the doctor, he says, Doc, I've been feeling pretty good. I mean, yeah, maybe I've packed on a few extra pounds around the waist, but in general, I'm feeling pretty healthy. Now, say both Joe over here and Bruce are seeing the same family practice doctor. So for Joe says, I'm worried about this thirst and urination and the losing weight. I think that we should probably check Joe's blood sugar. And then similarly with Bruce, even though he doesn't have any symptoms, the doctor recommends that Bruce has some routine screening done that would include checking his blood sugar. And it turns out that both Joe and Bruce have very high blood sugar. They have something called hyperglycemia, which stands for high blood sugar, and they're both diagnosed with diabetes. But how can such different situations with Joe and Bruce be caused by the same disease? Now, to answer this question, we first really need to understand what exactly diabetes is. Now, the first thing I want to mention is that I've been referring to diabetes mellitus, and there are a couple different conditions that have the word diabetes in them. But generally, when people refer to diabetes, they're referring to the disease diabetes mellitus, which is what we're going to be talking about. So diabetes mellitus is a group of disorders that are characterized by an inability of the body to regulate its blood sugar levels. You'll notice that I put glucose here in parentheses after sugar because glucose is the main type of sugar that the body uses. And this dysregulation results in high blood sugar or hyperglycemia. So to get a better idea of this, let me just bring in a simple diagram here. So this right here, imagine this is a blood vessel. And in this blood vessel, there is blood going through, and that blood has glucose. Now, glucose is sugar, and it's the body's preferred source of energy. And we get glucose from the foods that we eat, and then the glucose that we eat is stored throughout the body, but primarily in the liver here. And to regulate the amount of sugar that is in our blood, we have two hormones. The first hormone I'll have over here in orange is insulin. And then the second hormone I'll have over here in blue is glucagon. And then down here in green is a cartoon of some cells in the body that are going to need this glucose for energy. When the glucose level in the blood is getting too high, the pancreas releases this insulin. And what the insulin does is it stops the production of glucose or the release of glucose from the liver into the blood. And then it also has this glucose be taken up by the cells. And so this decrease in the amount of glucose being put into the blood from the liver and then the increased amount of glucose leaving the blood going into these cells causes that blood sugar level to go down. So insulin decreases blood sugar. But if insulin were to just act on its own, the blood sugar would be always way too low. So when that blood sugar starts getting to a lower level, the pancreas then will release glucagon. And what glucagon does is it causes the liver to release that glucose into the blood, that all that glucose that's stored there. And then it also causes the pancreas to stop producing the insulin so that less glucose is being taken out of the blood and put into the cell. And therefore, then the effect of this, by having the liver put glucose into the blood and then preventing the glucose from leaving the blood, glucagon results in an increased blood glucose level. So now in diabetes, this insulin here is either not being produced or it's not functioning properly. So just cross it out. It's not doing its job. And what happens is that the effect of glucagon here is amplified. So you get this increase in blood glucose levels. Then, as I mentioned, insulin causes glucose to exit the blood and go into the cells so that the cells can use the glucose for energy. But if it's not around, this doesn't happen. So despite the blood glucose levels getting higher and higher, that glucose isn't able to get into the cell, and the body isn't able to use all of that energy. So in a sense, despite the presence of plenty of blood sugar and energy, the cells are actually kind of starving. And that's actually what can go on. You can have this really high blood sugar level, but the body, in some senses, thinks it's starving. And this idea of starvation in the face of plenty of energy is a little bit confusing. Let me just make an analogy here to hopefully have it make more sense. So it's very similar here. Now imagine instead of this pink blood vessel, imagine this is a water main. Now, the purpose of that water main is to bring water to these houses. Now imagine that one of these pipes that went from the water main to the house is clogged. Now, despite plenty of water being traveling down the streets and being right by the house actually isn't able to get the water. And this is kind of like that same idea of despite all the glucose being in the blood, when you don't have insulin, you can't get the glucose into the cells, just like if you have a clogged pipe that prevents water from coming from the water main into a house. So now let's go back to Joe and Bruce and understand how you can have the same disease that causes such different presentations in different people. Remember I said that diabetes mellitus is a group of diseases. They're not all the same disease. So depending on the underlying mechanism that's going on, the disease can present in very different ways. So Joe over here on the left, he's a very typical presentation of type 1 diabetes. And I'm going to just abbreviate diabetes DM for diabetes mellitus. And in type 1 diabetes, Joe's body isn't producing any insulin, and that results in that high blood sugar. But over here with Bruce, he has a different underlying mechanism. His presentation is very characteristic for something called type 2 diabetes. And in type 2 diabetes, the body produces insulin, but the receptors on the cells are not as sensitive to insulin. So insulin just doesn't function like it's normally supposed to. And so it has a very different presentation, even though for both of them, insulin is not working properly and it results in hyperglycemia, which is the characteristic finding of diabetes. Depending on the underlying mechanism, whether or not it's not producing insulin or whether the insulin just isn't working properly, you still have hyperglycemia, but the presentation can be very different.
I thought that video was kind of nice in comparing type 1 and type 2 because they are both diabetes. They're just a different, they're different in how or what the dysfunction of insulin is. I don't know what that means. All right, so next we're going to go ahead and get into our Menti for today. So let me go to share. That's not what I meant to do. Present. That's what I meant to do. Talked before to you guys that diabetes is kind of near and dear to my heart because of my personal history with it. Anybody still need to get into the Menti? We're good. Yeah. Okay. So why it's near and dear to my heart. All right, this is my son, Preston. We talked about him a little bit. He's like the continuing case study for MedSurg. Poor kid does have a lot of issues. This is him almost 3 years ago. We can throw a little Christmas tree in the background. And about 3 years ago, we were gearing up for Christmas. No, it was after Christmas, excuse me. It was after Christmas. It was crazy time of the year. He had just had a cold the week before. He'd gone to a winter camp with our church and all these kids got sick. And of course he got sick as well. And that week at work, I was super busy. I wasn't home a whole lot, so I felt like I didn't see him as much as I maybe would have otherwise. And that Friday, after he was sick, he called me, and I was actually at the hospital working. And he goes, Mom, I think something's wrong. Now, the night before, my husband had been up with him, and that morning, my husband was like, man, something was really weird last night. Because sometimes he has dreams. If you have kids, sometimes they wake up with bad dreams. Usually as teenagers, it's not as big a deal, but he was like, my husband told me this was just acting so weird. Something was wrong with him. It's really strange. So anyway, and then it reminded me that as he was going throughout his day, when I was home the evening before, kept coming upstairs, like to our kitchen and like drinking water, like filling up his cup and drinking so much water. And then of course I saw him in the bathroom all the time. And I was like, oh, that's interesting. And I kept thinking maybe it's because his throat was sore, because he had a sore throat with his cold. He had to be, but he never used to drink water. I mean, that was very atypical for him. So then at Friday, I'm at work, and he called me and he goes, Mom, something's wrong. And he goes, I just stepped on the scale and I've lost 10 pounds this week. And my heart dropped because I knew, and he was wrestler back, or used to wrestle. So this was right after wrestling season. And so he was pretty used to weighing himself routinely. And so he knew kind of what he should weigh. Because I had missed the clues leading up to this that week. But as soon as he said he lost 10 pounds, I knew he had diabetes. Because all the classic things were there. He was eating all the time, which a teenage boy does. He was drinking so much water. He was peeing a lot. And we have that weight loss. We'll talk about why they have the weight loss in a little bit. It was big. So I just left the hospital. I mean, I handed off, I got somebody else to cover for me. I went home, and it's still like I can still see his face when I sat down with him and my husband and just explained what I thought was probably going on. And my son was just in tears, and he never cries. He's like tough kid. And I said, Bud, if this wasn't happening right now, if this wasn't what was going on, what would you want to do right now? And he goes, I just want to get on Xbox and play video games. I was like, okay, why don't you go do that? Go spend an hour. I'll take care of what we need to do right now, and we're going to take care of this. I called this pediatrician, and she said, bring him in. And so we got all those things ready. I went ahead and just packed overnight bags for us because I knew what was happening. We went to the pediatrician's office. It was really interesting to me because they didn't actually do a finger stick for glucose. What they did was check his urine. And his urine had a lot of glucose. She talked about his symptoms. He was like, yeah, I'm just thirsty all the time. It's like, I can't get enough to drink. I'm peeing a lot. And then we talked about his weight loss. And so she knew I was a nurse, and she was like, I think we know what's going on. She goes, I need you guys to go to Mary Bridge. So we went to Mary Bridge. Anybody want to guess what his glucose was when we got checked in? It was in the 600s. Right? So high. And when we think about like that video that we just watched, very typical of the kid, I can't remember what the name they had for that video, but Preston it's essentially, he has diabetes type 1, which is an autoimmune condition, meaning that his body started to attack his own pancreas. So, and it's not the entire pancreas. Our pancreas has a lot of functionality to it, but specifically the beta cells of the pancreas, they're the ones that produce insulin. And so essentially, this autoimmune condition goes to those beta cells and turns them off. So that is not producing insulin anymore. So over this last week, and so usually with type 1 diabetes, it's autoimmune. Most people, there's a lot of people that have this genetic component that don't actually develop type 1 diabetes. There's usually something that sets it off. Usually it's a viral disease. That's usually what we see, is that somebody who's been sick a week or two, a month before, and that's what's kind of triggered them for this diabetes, this autoimmune component to be active, to start turning off their cells. So question or just, yeah. Someone who has the genetic predisposition for diabetes. Yeah, it typically runs in families. My family has no history of type 1 diabetes, and neither does my husband's. It was really interesting during COVID, there was a very large uptick in type 1 diabetes. They found that after people, teenagers, kids contracted COVID, they were more likely, if they had that predisposition for diabetes, to actually to turn into diabetes, if that makes sense. I should look, there's an article that I read on the CDC last year, and it was talking about how there was this uptick, and they can't say that COVID caused diabetes, but they can say there's a strong correlation with this uptick in kids who have type 1 diabetes also had COVID. So again, I mean, COVID was a lot that went on. We're still kind of finding out how it affected people in our population. So Preston, after that glucose of over 600, we moved to the front of the line, which I kind of felt bad, you know, like as healthcare people. I mean, Mary Bridges' ER was full that night, and he looked fairly healthy. He was a little bit skinnier by this point in time, but he looked fairly healthy, and we were whisked back right away. And we earned ourselves a 3-day stay in ICU. And it was a crash course in how to manage diabetes. My personal experience is I don't know how parents or people who don't understand the body and the medical system able to effectively manage diabetes. You know, like in our 3-day length of stay in the hospital before they discharged us, that was normal. It wasn't expedited because I was a nurse. They do. Like, just think about that for a second. If people don't know about what diabetes is, about how to check blood sugars, about insulin or how to administer it, figuring that all out in 3 days is why. So we did though. We figured it out. My husband, who's not medical, doesn't like, he's not he's anti-medicine, but he's just like, that's your thing. I'm gonna live my life or die, whatever. He learned how to give my son his insulin. When you're learning how to manage diabetes, you know, we have a lot of really good tools that we'll talk about now. We have pumps that can deliver insulin, kind of more mimicking what the pancreas does. We have continuous glucose monitors. A lot of times you see people on the back of their arm, it's measuring their glucose values. But when you're newly diagnosed, they don't want you to use those. Anybody want to know why? It's not that it's severe. You don't know. Or it's more because those machines are really good, but we can also have failure too. And they want to make sure that if his insulin pump would fail, he knows how to draw up insulin and know what to give himself if that was necessary. Or if his glucose monitor stopped working, he would know how to check his blood sugar and manage that, right? You have to know the basics before you can go on kind of to the next step. But thank goodness I advocated hard for him to get an insulin pump because they are so much more effective at controlling blood sugars in a type 1 diabetic. And so after several months, he was so happy. This is one of his first, I think it was in his first month of getting an insulin pump. There's a few types of pumps that we'll talk about next week. This one is nice because it doesn't have it's all contained in one. So this is called Omnipod. It's one of the common ones. Every 3 days, he has to get a new one. He sets it up, fills it with insulin, and then it has a needle actually, and it inserts a cannula into his body, and it gives him a slow, it'll give some insulin based on what our pancreas. So if we think about our pancreas, and I like the video how it kind of talked about how the pancreas, it releases insulin, but it also releases glucagon. So when we talk about hormones that affect our blood sugars, insulin is one that helps to decrease our blood sugars, and glucagon is one that helps to increase our blood sugars. Now, how it works or how it does this is that insulin, I kind of like the video where it showed the house with the water main and how if the water main is clogged, even though you have all this insulin or water in the system, it's not getting to the cells or the houses. One the example or the way I like to describe to me was that you have all this glucose in your system. So like with Preston, he can have, like, eat a full meal and he can have glucose 600 plus, right? He can have really high glucose. But if he doesn't have insulin, that glucose can't get into the cells. I like to think of glucose as the key that opens up the doors to the cells. And if you have all this glucose, but you don't have the key to let it into the cells, all that glucose stays in your bloodstream and it doesn't get to your cells. So your cells are then starving. Think about all of your muscle cells, your brain, your bones, like all, like you need glucose for normal function. And if you're not getting it, what does your body do? We're fatigued and tired, but our body says, okay, I've got to find some alternative sources of fuel. And that's where it starts breaking down muscles and fats. And so we'll talk about ketoacidosis, which is a little bit different. A lot of people, like there's the keto diet, different than ketoacidosis. In the keto diet, people try to kind of starve themselves so they will break down fats, hopefully. That's because of a diet management. In ketoacidosis with diabetics, specifically type 1, it's because they don't have enough insulin in their body and their body starts cannibalizing itself, essentially. Even though they have all this glucose and they're eating and eating and eating, they don't have the key to get it into their cells for fuel. And so they start burning muscles and fat to get energy. Now, if you remember, I'm not going to take you through the Krebs cycle and all this stuff from biology, that you learned a long time ago. But if you remember, cannibalizing your muscles and fat is not a very effective form of energy, right? If we can metabolize that glucose that he has, we get a lot of energy. If we have to break down muscle and fat tissue, we don't get a lot of energy, but we get some. And our body's like, I'll take some over none. A byproduct of that are ketones. That's when we know that people are having kind of a hard time, especially in type 1 diabetes, because we start seeing ketones usually in their urine, but we can also see it in their bloodstream too. Ketones are an acid, they're very acidic. So sometimes people can go to a metabolic acidosis from having, usually it's type 1 diabetics that have ketoacidosis because their blood sugars are high, they haven't had enough insulin, the body is cannibalizing itself, it's breaking down these muscles and fats and producing ketones, producing so many ketones that all of those ketone bodies in their blood have made them acidic. So it's very interesting how our bodies work. Like we have a pancreas that just stops producing a hormone. They try to find a way around it. It's pretty amazing. I meant to find these pictures. I'll find them and bring them for next week. We didn't used to have insulin. And we've always had diabetes from the beginning of time. There's people who have had autoimmune components. So when they used to call it the wasting disease, because usually in type 1 diabetes, it happens usually in kids, usually less than 20, sometimes up to 40 or more. I mean, actually it can happen at any age, whenever that's triggered, like that autoimmune disease is triggered, but usually kids under 20 is when we see type 1 diabetes kind of occur or like start. Back, I want to say it was the early 1900s. If you had a kid that had diabetes, you wouldn't really know what was going on with them. They would start being very hungry and very thirsty, but they would be getting skinnier and skinnier and skinnier because their body couldn't use all the glucose, right? They weren't producing that insulin. They had wards of kids who were skinny, fatigued, tired. They would have this fruity odor on their breath. That's the ketones. As it kind of, it makes your breath smell kind of fruity. In fact, super gross. One way they used to diagnose diabetes is that physicians would go through in the first urine of every patient, they would take a little and lick it. Oh, it sounds disgusting, right? What do you think it tasted like? Sweet. They have all this glucose in their blood and they're not able to use it. So they're dumping glucose out in the urine, and their urine is actually a little bit sweet. I'm so glad that we don't have to do that anymore. So gross. But a couple hundred years ago, that's what they had. That's what they did. But back to these wards of these kids with the wasting disease. I don't remember what year it was. I want to say it's early 1900s. Somebody invented or was able to synthesize insulin. I want to say they got it from pigs or cows. They were able to extract it from their pancreas. These kids, within days, I mean, you should see the difference from when they started giving them little bits of insulin. And so they would get that little bit of insulin, and then their body's able to start using all that glucose in their system. Now their cells aren't starving anymore. They have energy. It's amazing. I'll find the pictures and show you the kind of before insulin was invented, and then these kids who were actually able to live because everybody else died. There wasn't a cure for it. There wasn't anything they could do. So anyway, it's amazing. Anyway, so Preston has a pump now. He has a glucometer. It all works in tandem together. We'll talk more about pumps and glucometers next week. And then I probably need to update this picture. I think this was homecoming last year. But that's him and my daughter, not his date. Because I don't know if I have permission from like his dates to like put pictures up, but I could put a picture of my daughter. Aren't they cute? I love them. Okay, so moving on through talking about diabetes. So pathophysiology, what's the abnormal? It's that that they have glucose intolerance, meaning if they eat glucose or sugars, they don't tolerate it. It can be for a variety of reasons. It might be like in type 1 diabetes where you're not producing insulin. Or it could be, like the video said, in type 2 diabetes where you're not absorbing or taking in the insulin like you should. It's an alteration of carbohydrate, fat, and protein metabolism, right? So if you don't have that insulin, you're going to start metabolizing and cannibalizing yourself. And there's long-term complications. We're going to talk about a lot of the complications of diabetes next week. All right, so just really quick, on the Metsy, tell me, so Preston is first diagnosed with insulin-dependent diabetes. What changed inside of his body? What's different? He did lose insulin or did lose weight, but more of the why is that his body attacked those beta cells in the pancreas. They're not producing the insulin. So nice job, you guys. So in type 1 diabetes, they used to call it juvenile diabetes. Well, what we found is that there's adults that get type 1 diabetes as well. So juvenile isn't really the correct name for it. Usually, or sometimes you might see this IDDM, insulin dependent diabetes, mellitus. Now, sometimes in type 2, we give people insulin as well. So that's not really a correct term either. We usually say type 1, and that's the autoimmune disease that attacks the pancreas. And then there's type 2, where you have insulin resistance, and then we'll talk a little more about it. So it's an autoimmune response, usually to a virus. You usually can almost pinpoint back to, hey, a couple weeks ago, they had this cold. They had a flu. It didn't mean they were so sick they were in the hospital or anything. They just had some sort of immune response that triggered this genetic component to the weight. The pancreas secretes no insulin. I will say there is a little bit of what they call a honeymoon phase, which is a horrible name for it because it was a nightmare. Essentially, in kids, the honeymoon phase is very short. In teenagers to adults, it could be up to a year. But it's where your pancreas, it doesn't just stop producing insulin overnight. In kids, it can be a few days to a week. It's a pretty short time. In teenagers to adults, it can be up to a year before your pancreas fully stops producing insulin, which in some ways can be nice, right? You're less likely to go into DKA because you do have some insulin that's getting produced. However, you're also trying to hit a moving target because we're giving him insulin. His body's still producing insulin. It's not always normal or in a pattern. That makes sense. So that first year was a lot because it was like, oh, how much insulin do you think you're gonna produce today? And you can kind of just go with it. More common, you're gonna see young, thin patients, and they are more prone to ketosis, like we talked about, because we don't produce insulin. So if they start to metabolize their fat and muscle cells, they're gonna produce ketones. So let's talk a little about George. George is kind of like the guy who was on the right side of the video. George is my father-in-law. George was a big guy. He always like played sports, but in his, midlife on, he was a bit thick, a bit heavier. He had hypertension, high cholesterol, all the things that you think, are just typical general unhealth. George started, I don't remember exactly how he was diagnosed, but he was eventually diagnosed with type 2 diabetes. So when they checked his blood sugars, sometimes he is up to 200-300, so he can get pretty high sometimes. And it's not that his pancreas isn't producing insulin, it is. But it's that his cells, we're Preston cells, he just needs some insulin to open the door, and the glucose can get in. For George, it's like, well, I kind of need 2 or 3 keys to be able to burst open that door. He needs more insulin to be able to open up the cells so that the glucose can get in. It's called insulin resistance. So where normal patients, maybe a type 1 diabetic, would only need, let's say, 5 units of insulin with their lunch. Somebody who has type 2 diabetes, that's insulin resistance, they might need 10 units of insulin, 20 units of insulin, because their cells need more insulin to be able to open up that channel to receive the glucose. Okay. So George is diagnosed with type 2 diabetes. Tell me, what's something that's different with type 2 diabetes from type 1, just from what we talked about so far? That's good job. Insulin resistance. Yeah, his pancreas can still produce insulin. He can benefit from oral anti-diabetic medication. That's a great catch. Usually for type 1 diabetics, they don't need oral diabetic medication. It's really what they need is insulin. They just don't produce it, and so they need it. With type 2 diabetics, and we'll talk more about the oral medications a little bit, they need some help. So type 2, former names, non-insulin dependent diabetes or adult onset diabetes. Again, those are old names, but you might see those sometimes you're looking through the chart, if you're talking to an older provider, they might say, oh, I have adult diabetes or something like that. Now, type 2 diabetes is a lot more common. But I want to point out the difference between the two, because how we treat them is very different. Right? Most of your patients, when you see diabetes, 95% of them, it's going to be type 2 diabetes. A lot more common. There is a genetic component to it, meaning, like if you have a dad or mom that has hypertension, you have a higher risk of having hypertension. It's the same thing with diabetes. You might have trouble with your insulin metabolism. They sometimes can have a reduced number of beta cells. So it's not that their beta cells aren't working, but some of these patients, they might not have as many, so they might not be producing as much. So not all, I guess I shouldn't say all type 2 diabetics have insulin resistance. A lot of them do. Some of them just don't produce as much, or sometimes as the disease progresses, their beta cells stop working as effectively. But for the most part, they're all producing insulin still. Reduced tissue sensitivity to insulin or insulin resistance. The largest risk factor is obesity, larger weight. There were studies, it's been years ago, that talked about if patients if they're overweight, if they can lose about 10% of their body weight, usually their diabetes symptoms will go away and they won't need medicine. Pretty amazing. Like a lot of patients, you'll see they have a history of diabetes. And it's like, well, what do you do to treat it? And they're like, well, nothing. I was really overweight, or my blood pressure was high, or whatever it was. but I started exercising, I lost some weight, and now I don't need to treat it anymore because it's controlled with their lifestyle choices. Doesn't mean if they gain weight and become inactive that it won't come back, but what they're doing helps to treat it. And they're not usually ketosis prone because they're still producing insulin. So even though their body isn't getting enough glucose into the cells, it doesn't have as much insulin usually as it needs. It's usually not to the point where they start to self-cannibalize and break down their muscles and fats. All right, so type 2 diabetes, there's a greater importance of lifestyle modification because really we can, and not everybody, I should say, not if you lose weight and exercise, it doesn't mean your diabetes will automatically go away. I have a neighbor across the street, Miss Betty, which I talked about her a little bit before. She is a spunky 75-year-old who lives alone and is so independent. And I was talking with her because she got a Dexcom, which is like the glucose monitor, and that was been about a year ago, and I think it's been about a month or two since I've had to help her. It was a journey because she doesn't like technology. She liked not having to poke herself all the time. So with the Dexcom, you change it every 10 days. So for about a year, I was over there every 10 days because she could never remember how to change her Dexcom. But, we were talking about lifestyle and things, and she goes, those doctors lied to me. She goes, I lost the weight, I exercised, my blood pressure is controlled, and I still have the diabetes. And I said, I'm sorry, but you're so much more healthier overall now, but she was really mad because she was like, I did what they said and it didn't work. But a lot of patients, it really can, and what I didn't tell her is if she was still overweight, if she hadn't managed other diseases, her blood sugar would probably be a lot more out of control, and it would probably be, her diabetes would be more difficult to manage if she didn't do those things. Yeah.
I'm kind of brain push, but it's kind of like where they're talking about, oh, you're right, cancer, or something that like where your pancreas stopped working, then it's actually part of
Yeah, essentially, if you had cancer that destroyed all of your beta cells, you would be diabetic because there's that insulin malfunction. Yeah, good question. So type 2, when we manage it, we usually start with oral medication. We're going to talk about different oral medications a little bit later because they work in a variety of manners. So I'm not going to get into that right now. Diabetes is chronic and there is no cure, regardless if you're type 1 or type 2. Type 1 is a little bit more difficult to manage in that it's lifelong. Even if Preston, my son, stays healthy and active and he exercises and everything else in his body is perfect, he's always going to need insulin. He asked me if he could go to the military not too long ago. And I was like, I don't think so, because you're medically disqualified, right? You have a long-term health condition that doesn't have a cure. Now, type 2 diabetes is also chronic. It can be managed oftentimes with diet and exercise, lifestyle management, but you still have diabetes. Just like somebody who has hypertension, if it's managed with their diet and exercise, it's not that the hypertension went away, it's that it's managed. With diabetes, if they take care of themselves, it could be managed without medication. So here's something that's interesting from the CDC. More than 34 million people in the US have diabetes. It's a big deal. You guys, if most of you guys have already gone to clinicals and seen patients, who saw a patient that had diabetes as part of their diagnosis? I was gonna say almost all of you I'm guessing saw somebody with diabetes. This is what's amazing. 34% of US adults have pre-diabetes. We'll go over pre-diabetes in a minute, but essentially it's kind of they're on track to develop diabetes because of what's going on with them. That's huge. And the cost is about over 325 billion a year. And that's in the management of the disease, the complications. Yeah.
makes sense being that if that person was exposed to something like
Typically with the pre-diabetes, it's type 2 diabetes because it's a combination of things. We look at pre-diabetes about your blood sugar levels, your cholesterol, blood pressure. It's kind of things that put you more at risk of developing diabetes. The type 1 diabetes, that's the autoimmune response. Here's something that when you're assessing your patients, most patients fall into two categories, either an apple shape where you're kind of round and you have a lot of, you're overweight, it's called trunkal obesity, or your trunk carry most of your weight, or you have a pear, or if they're overweight, oh gosh, pear shape, where they're more thinner up top, but then have more of their weight on their hips and bottom. Now, patients who are apple shaped are more likely to have cardiovascular disease, to have diabetes, to have a whole range of issues. So if your patient is overweight and they are in this pear shape, they're probably less likely to have a lot of long-term disease processes. Doesn't mean they can't have diabetes or high blood pressure, all those things, but where people carry their extra weight, and that's a genetic thing, right? If your mom was always smaller up top and had a big booty and hips, that might be how you are, and actually is really good that you might have less incidence of heart issues and diabetes. But if your parents passed on some genetics to be more apple shaped, more rounded throughout the trunk, that means you are higher risk, or your patients are higher risk of having high blood pressure, high cholesterol. And actually, it puts more stress on your body, your heart, and on your essentially organs. So type 2 diabetes in youth, we are seeing it. As we're seeing more kids that are inactive, that are eating unhealthily, they're developing blood pressure, they're developing type 2 diabetes, right? And so it's kind of crazy. It's definitely, our book says it's a nursing challenge, but I think it's a social challenge as well. Because if we can't establish some good health patterns in our kids now, it's going to be really hard as they reach adulthood. So a controlled type 2 diabetic state, the doctor said if my blood sugars remain stable, I might not need to take medication anymore or take medication. So which response is the most appropriate? Is it, it'll be placed on a strict low sugar diet for better control? Some doctors do not treat blood sugar elevation until symptoms appear. Diet, exercise, and weight loss eliminate the need for medication. And you misunderstood the doctor. Let's call for clarification. Let's see, where's the enter? There you go. Nice job. So yes, they might not need medication if they continue their lifestyle approaches. Let's talk about some of the wrong answers too. You will be placed on a strict low sugar diet for better control. Now, some patients are like, I actually have one of my next door neighbors is a type 1 diabetic, and he's in his mid-60s. He was diagnosed when he was a teenager, and he was telling me, like, he was diagnosed back before they had a way of doing finger sticks or checking blood sugar levels. They tested urine. So essentially, in the morning, he would pee on a little stick, and if it had sugar that showed up, he knew he had to take more insulin. I mean, it was like shooting in the dark trying to control blood sugars back then. It's amazing, and he was a really healthy man. And I asked him, I said, how did you control your blood sugars? He goes, well, I stopped eating sugar. And how sad is that? He didn't eat carbs like bread, like he really just cut down a lot of the need for insulin. You always need insulin. Which, let me go back for just a minute. So let's time warp back. One thing, an example I like to use to talk about the pancreas and how the beta cells produce insulin is like a faucet. So oftentimes like a leaky faucet. So everyone have a bathroom that has a leaky faucet, drips. You hear it at night sometimes, but sometimes you have faucets and they just drip, drip, drip. It doesn't matter how tight it is, it's always dripping out from the water. That's what our pancreas does. Right now, maybe we haven't really eaten anything, but let's just pretend we haven't. So our pancreas is just drip, 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 putting out a little bit of, because as we have our basic and metabolic needs right now, we all need a little bit of insulin when we leave and we go to lunch. A lot of our bodies will digest that and turn it into glucose, right? We're going to turn it into glucose that's in our blood. And our pancreas opens up the process and it produces a lot of insulin to get that glucose from that blood into all the cells and it gets to go.
after we eat. The faucet brings back down, and goes back to the drinking faucet. And maybe later tonight, going for dinner. Faucet cranks up, opens up. Turns off, it's really amazing, because when I think about how we try to dose people for insulin, like managing my phone, I'm like, okay, I know that this insulin takes about 15 minutes to start working, and you're going to take this in carbs, and so blood sugar is also this level, and so you do this like complex math, essentially, to figure out the blood sugar with the insulin dose should be. Our bodies do sugar without even trying. Like, I could go over here and just eat 5 candies, maybe I pick up 5. And then decide to eat 10, you know, my body is gonna adjust to that and produce the insulin that I need. Or maybe if I pick up 10 candies and end up only eating 1, my body, it automatically will give me the right amount of insulin at the right time to remain stable. And part of that too is the glucagon, right? Maybe, you know, I eat a lot of sugar, and then my body produces insulin, and then I'm like, oh, now I'm crashing, so I really didn't have any protein with that. My body will produce some glucagon to help maintain those glucose levels. So anyway, leaky faucet, it's a good way of thinking about how the pancreas normally works with us. Okay, some doctors don't treat blood sugar elevation until symptoms appear. So let's think about our type 2 diabetics. When do symptoms usually appear for them? I mean, they could be going on years and years of having high blood sugar levels. It's kind of like hypertension, where they don't call it the silent killer, but you can have a high blood sugar for a long time and essentially be pretty functional. All the while, it's causing dysfunction and it's causing complications, and it's not controlled. All right, so there's some other types of diabetes as well. Gestational, that's when women develop pregnancy, okay, develop a pregnancy, and then also develop diabetes. They do what's called a glucose tolerance test at, anybody know how many weeks they do it at now? I want to say it's like 30 weeks or somewhere a little bit later in the pregnancy. They essentially will say, don't eat or drink, come to the clinic. And then when I did it, this is way a long time ago, they had me drink this really sugary, gross stuff. And they would check my blood sugar right before I drink it, and then they'd check it about 30 minutes afterwards. Normal functioning means my blood sugar should be a normal level before I drink it, right? And then 30 minutes afterwards, blood sugar should be a pretty normal level, because my body will produce, it turns on that faucet and produces all that insulin to get that glucose in the my cells. Now, if somebody has gestational diabetes, they might not produce insulin like it needs to, or they might have a little bit of insulin resistance that's started. And so their blood sugar levels are going to be a little bit higher. So if you have gestational diabetes, most of the time it resolves after the pregnancy is over. It does make you more at risk of having type 2 diabetes though. So our patients that have had gestational diabetes, we always kind of monitor them a little bit closer, because we know that they could develop type 2 diabetes at a higher rate than our general population. Pre-diabetes, we'll talk about that in just a minute. And then secondary diabetes, this is kind of what you were talking about with if you have pancreatic trauma or cancer or something that goes on that kind of actually physically damages the pancreas, that can cause a type of diabetes as well. So we're going to do a little bit of true or false. So make sure you got your Menti up. When we're looking at diabetes, type 2 diabetes occurs as a result of lack of insulin production. Is that true or false? The main cause of type 2 diabetes is the lack of insulin production. And it is false. Type 1 diabetes, where the body does not produce insulin. You might have some lack of insulin production in type 2, but that's not the result of like what caused the diabetes. That's all I have there. Oh, okay, we got more of those coming up. All right, so pre-diabetes. So just to explain what this means, the arrows are like more abnormal. Up at the top, we talk about the this is fasting blood sugar, glucose tolerance, and hemoglobin A1C. So your fasting glucose normally, and what does fasting mean? Without eating, right? Usually it's about 6 hours without eating. Sometimes they'll say 8, just depends. But generally, if you hadn't had these food or even drink that goes in your system, you should have a glucose that's 100 milligrams per deciliter or less. Now, for pre-diabetes, your fasting glucose is probably going to be 100 to 125. It's going to be a little bit higher than normal. When you get to diabetes, your fasting glucose is going to be 126 or higher. Then you go to this glucose tolerance, right? So think back like to our pregnant gal that took the big glass of nasty stuff. Normal is going to be 140, right? There's going to be more glucose in our bloodstream, but because the pancreas has produced more insulin, we're able to move that into our cells. Now, somebody who has pre-diabetes, it might be 140 to 199. They're not quite able to either produce enough insulin or get it into the cells like it needs to be. And then diabetes would be 200. And I know I said the glucose tolerance test for pregnancy, that's where a lot of times we're more familiar with it. They'll do this to help diagnose diabetes. So you can be a man or a woman who's not pregnant and be given a glucose tolerance test to see how you tolerate the glucose. It helps to diagnose diabetes. Now let's talk about hemoglobin A1C. Hemoglobin A1C, remember we talked about there's certain lab values that would correlate with certain diseases or systems. So what is a lab value that we correlate with a myocardial infarction or heart death or cardiac death? The troponin levels, yeah. What about with renal disease? Creatinine, yeah. When we look at diabetes, one of the lab values we really want to look at is called a hemoglobin A1C. So hemoglobin, right? Those are red blood cells. They help pick up iron and take it around. Iron is used in them, but they pick up oxygen to deliver. Now, when you have a lot of glucose in your bloodstream, like our diabetic patients, these hemoglobin molecules actually get what's called blood loaded, and the glucose sticks to those hemoglobin molecules. And so we can see what patients' blood sugars have been through a 3-month cycle or 3-month average by looking at people's hemoglobin molecules and see how much glucose is sticking to them. 3 months, 90 days. What does that correlate to with our red blood cells? What's that? Yeah, red blood cells are produced, right? They live about 90 days. So that's why that test tells you for about the last 90 days. Now it's not perfect. I don't remember, I'm so sorry guys. There's a way to look at, I think your books has a chart that says normal hemoglobin A1C is less than or equal to or less than 5.7. That usually says your average glucose level, I think is less than 140. It's somewhere around. I was just saying that's what your average glucose level is. Now, if your A1C goes up, you have more of those hemoglobin molecules that have a lot of glucose on them. They're saying, hey, that's probably your glucose is, let's see, like 130 to 200, something like that. And then if you're up 6.5 or higher, I think that's like 200 or higher. Don't quote me on those numbers, but that's kind of what it means. The higher your A1C is, more glucose that's stuck to those hemoglobin, which means for the past 3 months, your glucose is probably been a bit higher. Now remember, this is also an average. So you can have somebody who's really high one day and really low the next. Okay, so it's not a perfect test, but it's pretty good because what we found is that patients are really good the day of their doctor's appointments, right? They might be not controlling their blood sugars at all, not doing a good job, but that morning, they're gonna take their insulin or they're gonna take their medicines, they're gonna skip their sugar soda they usually drink for breakfast and do what they need to do so that when they check their blood sugar when they come into the doctor's office, it looks great. But we're like, man, what's going on? They have all these other issues that really point towards a high glucose level. Well, that's because when they're not in the doctor's office, they're really not behaving as well. So this A1C level can really kind of tattle on them if they're not doing as well. My son is in a little bit of a pickle because being a 17-year-old boy and trying to, we're really working on this disease is his disease and we're there to support him. He also has that deviated septum, right? He wants to get it fixed. We saw the surgeon and she says, that's great. But your last A1C, I think it was 7 point something. So not that great. I mean, it could be worse, but I'd like to see it better. She goes, our anesthesia providers won't do surgery, even on diabetics, unless your A1C is 7 or below. Because that means that you're controlling your diabetes, you're more optimized and ready for surgery, and you're going to be healthier afterwards. So we have a surgery date set, but if we can't get his A1C at 7 or less, we're going to have to put that off, right? Until he is optimized. So I kind of remind him from time to time, I'm like, hey, let's keep that in mind, you don't have surgery. But in the day-to-day, when you're not having to show up at the doctor's office, it can be hard to do what you're supposed to, right? There's a study that was done by, I want to say Stanford, and it talked about diabetics. And I don't know if they were looking at type 1 diabetics. It could have been type 2 as well. But they essentially make about 280 more decisions a day than a non-diabetic person. And I absolutely think that's true, because in the morning, when I look at my son, he wakes up, first thing he should do is look at his blood sugar. Where am I? And then decide, do I need insulin or do I need to eat? Or do I need to put a new pump on? How's my Dexcom? You know, then go get ready for breakfast. What he should do before he goes to breakfast is think, what am I hungry for? What am I going to eat? And then I probably should bolus or give myself insulin about half hour before I eat. And then go eat. And then as he's getting ready to go to work, he might think, you know, I think I should get a workout in beforehand. Do I need to eat a snack? Or maybe not eat a snack based on where my blood sugar is at. And then later he goes to work, he needs to think about, do I have enough insulin in my pump to last me through the end of my shift? Does my Dexcom going to last me? Do I have my emergency supplies with me? Like, there's so much that goes into managing diabetes that it can be very exhausting. You know, we think about hypertension as another long-term disease that can have a lot of negative effects. But it's nice that with hypertension, if you're on medication, you know, it's a 1-day pill usually, once a day, twice a day. And if you do that, you've managed it usually. You know, there's still that lifestyle things we want you to do. With diabetes, you can't just take a break from it. You know, you take a break from diabetes, and usually you end up pretty sick. Yeah. Oh, great question. Yeah, we'll talk more about pumps next week, but the question was, what do you do? Pumps are wonderful because they act like that leaky faucet. You work with your doctors to get a prescription available from the settings for the pump. And so Preston's pump, it always gives him a little bit of that leaky faucet. And then when he eats, he tells it, hey, I'm eating 30 carbs, or really it's more like 100 or 150. The kid eats so much sometimes. And then the pump will give him kind of that open faucet dump of insulin. What's really amazing is that the pumps they have now have automated modes, which are supposed to more closely mimic like increases, where if his blood sugar is trending up, that little drip that it gives him will get bigger. It'll give him more as his blood sugar is going up. And if his blood sugars are trending down, it actually tightens up and won't give him nearly as much to help keep him more stable. I mean, the technology is amazing. As amazing as it is, it's nowhere near what our bodies do naturally, but it's pretty amazing. Okay, metabolic syndrome. This is something where it's more like a bunch of symptoms or lab values that put you in metabolic syndrome. Usually it's not the patients feel bad. It's just looking at them and looking at their labs. We can say, oh, you have metabolic syndrome. That's when you're at high risk of developing diabetes type 2 specifically. So if you have a waist circumference, and I think in your book it has this, but just say elevated waist circumference, larger than you want it to be. If your triglycerides are elevated, if your LDL or low density lipoproteins are high, or if your HDL is low. So when the HDL is good cholesterol, that's protective. You want it to be higher. If you have elevated blood pressure, elevated fasting glucose, you are at greater risk of type 2 diabetes. And sometimes it doesn't mean you have all of these things, it might just be 4 or 5, like 4. If you have several of these, it means that you probably have metabolic syndrome and your risk of developing type 2 diabetes. So, a nurse is providing education on a client who's newly diagnosed with diabetes.
What are classic symptoms associated with diabetes? You guys, so I like the word clouds because the more people answer the same answer, the bigger the word gets. And the 3 biggest words here, polyphagia, polyuria, and polydipsia. Those are the 3 classic signs of diabetes. And a lot of you guys kind of said excessive thirst. What's another name for that? Polydipsia, right? I thought they put anyway, polyphagia, what does that mean? Excessive hunger. Why are they hungry? Yeah, their cells are starving. They have a lot of glucose in their blood, but their cells are starving. And then polydipsia or polyuria. Yeah, why are they urinating all the time? Your body's naturally trying to flush out all that glucose. If it's, especially in type 1, if they're getting ketones, your body's trying to self-regulate the acidosis and kind of bring you back in more of a normal function. But usually we see the urine because of the polydipsia, because they're drinking so much. All right, so the classic 3 Ps, polydipsia, polyuria, polyphagia, they often can be dehydrated, even though they keep drinking very much. We'll still see dehydration. They're very fatigued because, like we said, their glucose is high, but their cells are starving. Often can have blurred vision. They're more prone to infection. This is more of the some of the complications that we'll talk about next week. We'll explain why. Abdominal pain. Sometimes, I lost my little pointer. As those ketones and everything, they're pretty acidic. It can cause some issues with your stomach as well and cause stomach pain as well. Headache, and then ketosis, acidosis. Now, these are all, when we say they're signs and symptoms of diabetes, they're really signs and symptoms of high blood sugar. But like type 2 diabetes is our most common type of diabetes. Usually we diagnose it by diagnosing the high blood sugar. So how do we diagnose it? Fasting blood sugars greater than 120. They might do a random blood sugar and just kind of any time of the day, whatever it is. If it's still over 200, that's significant. The glucose tolerance test over 200 after 2 hours, or the hemoglobin A1C greater than 6.5. So a client is evaluated for type 1 diabetes. Which client comment correlates best with this disorder? I'm thirsty all the time, I can't get enough to drink. Seems like I have no appetite, I have to make myself eat. I cough and I have a cold and cough that just won't go away. I notice pain when I urinate. And yeah, right, they're polydipsia, they're thirsty all the time. Good job. A nurse reviews a client's hemoglobin A1C, which test indicates a client's blood sugar has been well controlled. So time out really quick. What is this question asking us? Yeah, well, what's a good A1C? What's a normal A1C, right? It's always good to say, like, what is this question asking us? What's a normal A1C? And oh, look, you guys got it. Good job. Right, so 6.5, that's going to be a good A1C. Prevention, like I talked about, a little bit of a body weight loss, even a 7% one. Moderate physical activity, so it could just be walking, right? Some patients who struggle, I say, walk in your home. You have a room, go back and forth a little bit, some movements. And then sometimes they do metformin from other diabetic medications. goals, what we want to see is pre-prandial glucose, 80 to 130. What does pre-prandial mean? Before meals, right? So fasting, that's usually in the morning or if they haven't eaten at all. Pre-prandial just means before meals. So right now, before you guys eat lunch, that would be a pre-prandial. Peak postprandial glucose. So after you eat your food, we want to see you kind of peak up at 180. We don't want to see you go higher. And then we're going to be looking at your blood pressure as well. You know that blood pressure disorders can also affect, make you high risk of having diabetes complications. And we're going to hopefully have them a glycohemoglobin. So hemoglobin A1C, you might also see glycohemoglobin of less than 7. We're going to talk to them about nutrition, exercise, medications, how to monitor their sugar, and then other education pieces. What are risk factors for type 2 diabetes? Select all that apply. All right, so yes, obesity is a risk factor, hereditary, right? Can be hereditary. Metabolic syndrome, we know if you have that, you're higher risk, and if you have insulin resistance. But those islet cell antibodies, good job, they are not a risk factor. So management, it depends on the diet, or pardon me, it depends on the type, but diet and weight loss are a major component of treatment, especially for type 2 diabetes. We want to have them exercise regardless if they're type 1 or type 2. I think we're almost at the end, you guys. During client teaching, the nurse reviews insulin secretion. The nurse is correct when she states that insulin is secreted from where? Where do we have insulin secreted from? Good job, beta cells. Anybody want to guess what alpha cells produce? Glucagon, yep. A 26-year-old patient admitted to the hospital with a new diagnosis of diabetes, blood glucose level of 680, and ketones in the blood and urine. Which type of diabetes should the nurse suspect? Oh, good job. What was our key piece there? The ketones, right? That's type 1 diabetes. All right, last piece. Name that diabetes. And if you don't want to be in the Menti, we can just say it too. All right, so they're going to need insulin for the rest of their life. Type 1 or type 2? Yeah, maybe hold your finger up like 1 and 2. To somebody else. And yeah, you guys are right. Type 1, right? For the rest of, unless there's a cure, my son keeps saying that there might be a cure. If we can figure out, because the beta cells, it's not that they're destroyed, they're just not producing insulin. So if we can figure out genetically how to go in and turn them back on, we could cure type 1 diabetes. I hope it happens. Can be managed by weight loss and diet. Yeah, type 2, it's going to help type 1 patients, but really it's not going to manage the disease. We'll usually begin with oral hypoglycemics. Yeah, type 2. Is at bigger risk of DKA. Than type 1. Yeah, type 2 usually doesn't go into DKA. So we'll talk about some of the medications next week. And that's it. So if you were not planning on going to the success class tonight, what's that? Oh, she did. I'm so sad. Whenever she does do it this week, she's actually talking about, I gave her information about the oral diabetes agents. It's an insulin. We'll talk about it in class, but I think that's something that students struggle with. So try to attend success class. Sorry that I got canceled again. And then if you're in my clinical rotation this week, stay after for just a minute so we can talk about a few things, not much. All right, thank you guys. Don't forget to turn in your KWLs. Bye. Bye. Have a good one.